Globally, over 1 billion people are affected by neglected tropical diseases, or NTDs. Liberia is one of the first countries in the world to introduce integrated case management of skin NTDs, including mental health care for people affected by skin NTDs. Following a request from the Ministry of Health in Liberia, Redress was designed to evaluate and enhance the existing integrated approach pioneered in Liberia. By using a participatory action research approach, Redress amplified the voice of people affected by skin NTDs through their involvement as co-researchers within community advisory boards and participatory workshops to guide the development of this integrated approach to healthcare.
Me being persons affected, been stigmatized in the community for a long time, and then just got successful with my treatment, and then was recruited by Redress to serve as co-researcher, serve as peer advocate lead, serve as chair for the community advisory board. So this has made a great impact on my community, and I make more people to come around me. It has broke stigma on me. I'm well known in my community now, and I become decision maker in my community through Redress activities.
Redress was needed because we needed to have evidence of better model of implementation.
We already had this existing training manual for case management entities. So Redress built on that and then included other diseases that were not within the case management or training manual. And then most importantly, Redress also integrated mental health into entities. There was gap when it comes to providing psychosocial support for patients affected by entities.
Before Redress, at the time, NTD patients were just basically in communities. They were very scarce to be identified. They were living to isolated places, and there was no proper care.
But when Redress came and they trained everybody, so we started talking to them. They started to understand and come into the health facility.
After I was infected by NTDs, we were using some puncture medicine out, but no way. So later on I met the health person. He invited me to the health clinic. I started taking my medication. I started getting better.
The core component of the intervention was like a pyramid. So at the base, you have nationwide sensitization. What we had to do was to sensitize the community health workers on case identification, referral, and the provision of basic psychosocial support at that level. Look for cases and then also reduce stigma. And then from the population-wide initiative, you move on to family and community initiatives. Redress was able to establish peer support group of persons affected, which we never had in this country before. We had to train community health workers on the basic psychosocial support and also on the local listing link on referring cases to the health facility. The pyramid also going upward, you have the decentralized management of patients. At this point, health workers have been trained in the clinical diagnosis of NTDs and also on the basic psychosocial support of persons affected, especially those that are presenting with signs and symptoms of mental issues. And then at the peak of the pyramid, you have the tertiary level. At this level, you have clinicians that are trained in image gap, and their responsibilities at this level is to train or take care of patients that are referred.
Redress had impact for a wide range of people, including persons affected, health workers, health managers at the county level, and national policymakers. In fact, there is even global impact with other countries interested to learn from Liberia's approach.
The integration of mental health, through the Redress study, it has positively impacted the program. In fact, presentations from the dissemination meeting, findings that were presented, shows to the audience that Redress did a lot. Before then, the gap that was there, but after the integration of entity with mental health, we saw the improvement in people affected by entities associated with, mental health.
Persons affected formed peer support groups where they shared and provide care and encouragement to their fellow group members.
Oh, the peer support group came in and helped me a lot. Before I used to be ashamed, but since they came, they talked to me, they counsel me, they made us to be together, we lecture, we have meetings, make fun with one another. I can feel free to go anywhere, I can be ashamed now.
After we're not ready, focusing on it, and we didn't know how to do the diagnosis of it for referral. So we just saw it or traditional sickness that people had, and we just going on our normal routine. But since Redress came in, we went for the training, we got to understand how breathing ulcers, they so look like from the ordinary soul. So we come back to the community and we started searching for these cases.
But since we got the training, and then we know that the patients are special category of patients that we need to treat them with care, so it actually makes a difference. We are not misdiagnosing.
After the training now, you see that traditional healers now referring cases to the hospital. Faith healers are now referring cases to the hospital.
Whenever they bring such patients, I will take them to the health team, and when the health people give up, then I come in. We're working together.
The legacy of Redress, I think, is about sustainability, evidence-based program establishment that will lead to policy change and having impact health-wise on people affected by neglected tropical disease. We're getting invitations from other countries now to see how we can support adapting some of the learnings we have here. Like the Africa CDC, I think they are very interested in seeing the level of work Redress did with the Ministry of Health.
The integration is being adopted by the national program. The integrated package is a legacy. It was a collaborative effort that came about through Redress. So that's a legacy that Redress has left behind.